Okay. Welcome, everyone. So today we have three presenters with us. I will just introduce them and then we'll get straight into the webinar. First, we have Hilary Brown, who is an assistant professor at the University of Toronto, Scarborough, and the Dalai Lama School of Public Health. She is cross-appointed to the Temerty Faculty of Medicine's Department of Psychiatry and is an adjunct scientist at Women's College Hospital and ICES. Dr. Brown holds a Tier 2 Canada Research Chair in Disability and Reproductive Health. Her research program uses epidemiologic methods to examine maternal and child health across the life course, with a particular focus on populations with disabilities and chronic disease. Leslie Tarasoff is a postdoctoral research fellow at the Department of Health and Society at U of T Scarborough as well, and at the Azrieli Adult Neurodevelopmental Center at the CAMH. She holds a PhD in public health sciences with a specialization in women's health from U of T. Primarily using qualitative methods, her research explores the reproductive, perinatal, and mental health of often stigmatized and marginalized women, notably women with disabilities and sexual minority women. Momina Khan is a second-year Master of Public Health student at the Dalai Lama Public School of Public Health at U of T. Her research interests are diverse but focus largely on reproductive and child health. Momina completed her first practicum under the supervision of Dr. Brown and Tarasoff, with a focus on the perinatal healthcare experiences of women with intellectual and developmental disabilities. So thank you through all three for presenting for us today.
Great. And thank you very much for the introduction. And thanks to everyone for being here this evening. So as Emily mentioned, we'll be talking to you today about a large study that we've been doing on disability and perinatal health in Ontario. And as you've gathered from the introductions, you'll be hearing from three of us. And so I'll be starting. So I'll get Leslie to take us to the next slide. So just a couple of acknowledgements before we get started. Like I said, this is quite a large study. It's a National Institutes of Health funded study led by myself and Dr. Yona Linsky at CAMH. And we also have co-investigators at Women's College Hospital, Sick Kids, St. Michael's Hospital, Ohio State University, and Virginia Commonwealth University. And importantly, we're supported by an advisory committee comprised of people with lived experience of disability, as well as health and social service providers and policymakers who have been really critical in terms of determining the direction and priorities of this project. Next slide. So we have a couple of goals today. I'll be starting off by sharing some population-based research on preconception health characteristics, as well as perinatal health outcomes of women with disabilities. Then I'll turn it over to Leslie, who will be discussing findings from a qualitative component of the study, where she interviewed people with disabilities about their perinatal healthcare experiences. And then finally, Momina will discuss what these data really tell us about recommendations for improved clinical care during pregnancy, as well as delivery and postpartum for people with disabilities. Okay, next slide. Okay, so by way of context, disability is common in women of reproductive age, with at least 12% of women between the ages of 15 and 45 years reporting some kind of physical, sensory, or intellectual or developmental disability. Now, historically, the sexual and reproductive health of people with disabilities has been neglected, and there's a complicated history behind this, but it really relates to histories of institutionalization as well as involuntary sterilization in this population. In 2005, there was a landmark report from the World Health Organization, which issued a call for better reproductive health care among women with disabilities among member nations. And in 2006, the United Nations Convention on the Rights of Persons with Disabilities highlighted the importance of protecting reproductive rights of people with disabilities, including the right to good sexual and reproductive health, as well as the right to determine the number, timing, and spacing of one's pregnancies and the right to parent. However, despite these major advances on a policy front, women with disabilities continue to report being underserved and underrepresented in reproductive healthcare settings. Next slide. So that leads us to the population-based study that I'm going to describe. So based on this history related to disability and reproductive health, the aims of our study were really to understand the perinatal health outcomes and healthcare experiences of women with disabilities in Ontario, with the goal of improving obstetric and related reproductive health services. And the first part of this study was a population-based study. And our goal with this part of the study was to use province-wide data to examine preconception health, pregnancy rates, and perinatal health outcomes in women with disabilities compared to those without disabilities. And I'll just give you a little bit of information about the data that we have available to us in Ontario to do this. So in Ontario, we have the benefit of having health administrative data on all residents of Ontario dating back to the late 1980s, so over 35 years of data. And these data are anonymized and they're linkable across time. And what they do is they allow us to understand a person's full history of physician visits, emergency department visits, hospitalizations, as well as some basic demographic data. And so what we're able to do with these data is to understand disability-related diagnoses that are recorded in a person's medical history, including any notation of a physical, sensory, or intellectual or developmental disability, as recorded in those physician visits or acute care visits. And we're also able to understand these diagnoses in the perinatal period and to link this information with mother's data as well as baby's data to understand perinatal health outcomes as well. So next slide. So just to give you a sense of what our cohort looked like, we were able to use these data to accrue a large cohort of about 200,000 women with disabilities in Ontario who had at least one or more pregnancies between 2003 and 2018. And this figure here shows you what this group looked like in terms of their recorded disabilities. The largest group included women with physical disabilities, with the most common being musculoskeletal disorders such as rheumatoid arthritis, followed by neurological disorders like epilepsy and multiple sclerosis, permanent injuries like spinal cord injuries, and congenital anomalies such as spina bifida. We also included women who had sensory disabilities, including those with hearing loss as well as vision loss. And women with intellectual or developmental disabilities included those with an intellectual disability such as Down syndrome or other chromosomal anomalies, as well as developmental disabilities such as autism. And finally, we were also able to capture whether women had two or more of these disabilities, with the most common group being those with both a physical and a sensory disability. So next slide. So our first analysis with this cohort looked at women's preconception health, which we defined broadly as the health of reproductive aged women who could become pregnant. And we looked at a number of indicators of preconception health, including social indicators such as socioeconomic status, chronic health conditions such as diabetes, mental illness and substance use disorders, use of potentially teratogenic medications, as well as a person's history of having experienced assault. And what we found was that women with disabilities experience disparities on many markers of preconception health. Notably, disparities included higher rates across all disability groups of chronic conditions, mental illness, teratogenic medication use, and a history of experiencing assault. Although there were disparities for all groups, it's important to note that women with intellectual or developmental disabilities tended to experience the greatest disparities. And so together what these data tell us is that reproductive age women could enter pregnancy with known risk factors for adverse perinatal outcomes if they had a disability. Next slide. Our next study looked at pregnancy rates among women with disabilities in Ontario. And I'll just walk you through this figure. So as you can see from the black line at the top of the figure, the pregnancy rate in women without disabilities has remained somewhat steady across time and has actually even decreased slightly over the last 15 years. And in contrast, what we see is that pregnancy rates in women with sensory disabilities, which is the greenish line, as well as multiple disabilities, which is the dashed gray line at the bottom, have actually increased. And in 2017, nearly 1 in every 8 pregnancies were to women who had some sort of disability-related diagnosis in her medical history. And that was a really important finding because typically we think of this group as being not broadly represented in the obstetric population, and this really challenges that notion. Next slide. The other thing to note here is that although pregnancy rates were somewhat lower overall in women with disabilities compared to those without, when we look at pregnancy rates by age group, one important finding that I'll highlight is that adolescent pregnancy rates are actually higher in all disability groups compared to women without disabilities, who are in the final bar in the black on the right. And so together, again, these data really emphasize that this is an important and sizable population that could benefit from better perinatal supports. Next slide. So over the next couple slides, I'll highlight some of our findings related to maternal and newborn outcomes. And just to orient you to the figures again, each of the disability groups are in the colored bars with the black bar for women without disabilities on the right of each outcome. And what you'll see is really a consistent story for each of the outcomes that we looked at. So first, women with disabilities in each disability group were at elevated risk for severe maternal morbidity. So that's life-threatening pregnancy complications such as hemorrhage and sepsis, or maternal mortality in pregnancy and postpartum. They were also at increased risk for postpartum hospitalizations, including both non-psychiatric as well as psychiatric hospitalizations. And I'll just make a quick note that we also looked at complications such as gestational diabetes, gestational hypertension, and cesarean delivery. All were elevated across the disability groups compared to those without disabilities, but the difference in risk between the two groups was smaller than the ones that you see on the figures here. Okay, next slide. And turning now to the newborn outcomes. Newborns of women with disabilities were at increased risk for preterm birth. There was also a small increased risk for gestational age, as well as neonatal morbidity, which was a composite of significant outcomes such as sepsis, respiratory distress, and neurological problems. And we saw similar results across the other outcomes that we looked at, including NICU admission, neonatal abstinence syndrome, congenital anomalies, as well as neonatal mortality. And so just to make sort of a general comment about these findings, these data really show us that these are important disparities across the preconception and perinatal period that need to be understood. And we need to understand the reasons for them and what we can do about it. And that's really what the qualitative data enable us to do. So with that, I will turn it over to Leslie.
Thanks, Hillary. Maybe just before I talk about the qualitative data, I'll just ask a question that someone put in the Q&A, because I think this speaks to the quantitative data. So someone asked, what does the increase in pregnancy rates in those with sensory disabilities imply?
That's a good question. So I think these data really speak to a finding that has been suggested from other jurisdictions, which is pregnancy rates have increased over time in women with disabilities as there are more opportunities for child rearing, which maybe there weren't in the past. And hopefully that's an indicator that women are feeling that they have somewhat more support than maybe was the case 20 years ago in order to have pregnancies. But certainly there are still barriers that need to be addressed that we'll get into with some of the qualitative data. But it does imply that more women are having babies than there were before if they had a disability. Yeah.
So I'm going to be presenting now on the qualitative data. And like Hillary said, these data come from interviews that I conducted with peer researchers. So 2 women with physical disabilities conducted these interviews with me around the province. for people with physical, sensory, and intellectual disabilities. And we purposely used the language of people because there were a few participants who did not identify as cisgender women. So our approach to this qualitative part was really community informed, and our advisory committee that included women with disabilities as well as people that work for different disability related organizations provided a lot of feedback on the questions that we asked, and they also helped us with recruitment. And then for the interviews, we generally aim to understand what people's perinatal healthcare experiences were like. And there were sort of two components. Oops, I forgot to advance the slide. Two components to this. So one was really talking to people with disabilities who had recently given birth, so in the last 5 years in Ontario. And then we also conducted interviews with health and social service providers, but I won't really be speaking to those data today because we haven't really gotten far in the analysis yet. And so, like I said, we conducted interviews with 31 people across the province who had recently given birth. And the interviews were quite broad, but they focused on the services and supports that people access during pregnancy, labor, delivery, and the early postpartum period. We asked people what they liked and did not like about the services and supports they received, or what they found helpful or maybe not helpful and wished, were available. And then we also asked them to comment on their recommendations to improve care. So we're currently busy analyzing all these data. So what we're presenting is somewhat preliminary, but we're getting deeper and deeper into it, and I'm excited to share some things with you today. So like I said, I'm mostly going to focus on the data concerning the people with disabilities, but because we are presenting to a healthcare provider audience, so you as nurses who are joining us, I thought I would just highlight a few things about the providers that we interviewed. So out of the 31 health and social service providers and decision makers, 18 of those were healthcare providers. And here's the breakdown of the different providers that we interviewed. And many of these were identified by members of the research team and advisory committee as people who had, or providers who had experience working with women with disabilities, but not all of them had a ton of experience. But it was interesting when we asked how many had received training about disability, either in nursing school, medical school, continuing education. Very few indicated that they received any disability related training or education. And of the 6 nurses that we interviewed, only one of those said that they received any disability related training. So it's really great that many of you are here today, and hopefully you can share with your colleagues some of the things we share with you today. So here's just a breakdown of the people that we interviewed. So they really varied in terms of disability type, and physical disabilities ranged were quite broad. So we had someone with participants with rheumatoid arthritis, cerebral palsy, muscular dystrophy, MS, spinal cord injury. And then in terms of sensory disabilities, we had some participants who were deaf and who required us to have ASL interpreters at the interviews. We had 2 participants who were blind, and then some others who had partial hearing or vision loss. And then in terms of intellectual and developmental disabilities, this also ranged too. So we had 1 participant with autism, 1 participant with FASD, and some others with mild intellectual and developmental disabilities. And 18 of the participants used an assistive device or a communication aid. So this could be a wheelchair, a walker, a cane, special grips or tools, communication aids. And you can see there the age range of participants. So most of the participants were over the age of 26. And just a little bit more about the participants. As I mentioned, we used the language of people because not all participants identified as cisgender. However, most identified as heterosexual. Many were married or in a common law relationship. And about 2/3 of the participants identified as white. 25 of the 31 participants were born in Canada, and almost 2/3 lived in large urban centers. And in terms of education, about half of the participants, 15 of the 31, indicated that their highest level of education was high school or lower. And here's just a little map of Ontario, and you can just kind of see where the participants live. So we really hoped to get participants from all across the province, but I think what's common, we did get quite a lot sort of in the greater Horseshoe GTA area, but we did get some participants, in Ottawa, in Southwestern Ontario, and a handful in Central and Northern Ontario as well. So what I'm going to do is talk about some common themes and experiences that came up among the participants based on disability type. So first, I will talk about the participants with intellectual and developmental disabilities, and then I think I'm forgetting how I ordered this, sensory disabilities, and then physical disabilities. But I think it's important to note that some of the things that specific disability groups talked about could apply to all three of the disability groups. And I think this first one around fear of stigma around disability and being treated differently is something that came up with all the participants, but specifically for those with intellectual and developmental disabilities, there's some nuances here because for some of them, their disabilities weren't particularly visible. So if someone is blind or has a certain type of physical disability, that's not something that can really be hidden. And a healthcare provider will usually recognize that in their interaction with the patient or the person with a disability. But so many participants with intellectual and developmental disabilities talked about how, they were afraid of being treated differently because of their disability, and in some cases decided not to disclose their disability because of those fears. However, those decisions not to disclose disabilities may have contributed to gaps in care or sort of prevented them from accessing supports that might have been helpful for them. And some participants also talked about inaccessible care interactions. So healthcare providers using language that was really complicated or not taking the time to explain different procedures and tests to them. And then specifically with the intellectual and developmental disability group, several of them indicated that they had involvement with child protection services, either during their most recent pregnancy or with previous pregnancies or older children. And many participants talked about sort of what we identified as formal and informal policies that might identify or flag them as being high risk or at-risk parents. So in this next slide here, I'm just going to read out some quotes from the participants that sort of highlight some of these themes that I just mentioned. So the first one says, "I never told the doctors that I had a disability. I felt ashamed. I felt embarrassed. Didn't want to admit to myself, well, I knew, but I was still trying to hide it from myself too at the same time. And I didn't want people looking at me differently because I had a disability." So regarding inaccessible healthcare communication, one participant said, "Dumb it down so you understand," because they like to use these big ass words and you're just like, okay, they'll say it in another way, but I still don't understand. So I'm like, okay, sure. I just agree at that point. Stop talking doctor terms. So this is kind of speaking to the complicated nature of some medical jargon and how it's not accessible for some people with intellectual and developmental disabilities. And finally, with regard to children's aid or child protection, one participant said, "I was very quiet about my disability for a long time because back in the day, I knew children's aid judge people over that. I feel like they red flag you just because you might have a disability. They might be like, oh, maybe she can't take care of this kid." So of the 10 participants who had an intellectual disability or an intellectual disability and another type of disability, 5 of them had current or previous involvement with children's aid. So next I'm going to talk about some of the experiences shared by participants with sensory disabilities, and specifically those participants who were deaf or had hearing loss talked about unmet communication needs. So specifically lack of ASL interpreters or qualified interpreters. So interpreters not being there throughout their perinatal care experience. So whether it be at appointments with their family doctor, obstetrician during pregnancy, and especially sort of maybe when things went wrong or interpreters should have been there during labor and delivery, and also the importance of having interpreters available in that immediate postpartum period, and also when participants access other services in the postpartum period or even during pregnancy outside of hospital. So that could be prenatal classes or having a healthy babies, healthy children nurse come to your home and them not realizing that you're deaf and there's no interpreter and sort of the chaos that comes with that. And then some participants who were blind talked about inaccessible resources. So resources not being tactile and the failure of providers, including nurses, to really show them and teach them how to do things, and how just that few minutes of hands-on teaching would have made a world of difference. And this is specifically around breastfeeding. This is something that a number of participants talked about. As an example, one participant said, "I only had the interpreter for the delivery and then that was it. And she did come back the next day, so just to touch base with the doctors, but that was it. The nurses they come in a lot when you're in the hospital. They're doing blood work, they talk to you about how to breastfeed. All this stuff is afterwards, and there's no interpreter for that. I really should have had an interpreter every night I was in the hospital until I went home with my baby." Another participant, so just kind of caution with this quote. So this was a participant who was deaf and one of her twins was stillborn, and there wasn't an interpreter present at the birth. And she shared that, "I was getting prepped for surgery, emergency C-section, and I had no interpreter. I could see my husband was crying and there was no interpreter around. And the nurse came back and she said something to my husband and he was listening. And my husband was just in total shock and he signed DEAD to me." So her husband had to act as an interpreter in that really hard moment and tell her that one of the twins had died. So this quote just is going to stick with me forever. And it really shows sort of the health and emotional consequences of not having an interpreter present, how that was really unfair, that her husband had to be in that position to communicate that hard news to her when that was something he was experiencing too. So it just shows how it's so important to have an interpreter, especially if, there's a complication or, a loss. And another woman who was deaf talked about how her pediatrician refused to get an interpreter. So one of her, this was another participant who was deaf and just happened to have twins, was tongue-tied and wasn't eating well, wasn't gaining weight. And the pediatrician failed to recognize this and started blaming the mother. And at one point, Children's Aid got involved and ultimately showed up at their home. And again, there was no interpreter present, but ultimately when an interpreter was present, all this got sorted out and, the tongue-tie issue got resolved, but there was a lot of miscommunication, misunderstanding, and blame put on the mother because of the miscommunication and the lack of an interpreter. And finally, one participant who was blind, and this speaks to the importance of, taking time to teach people and really showing people how to do things hands-on if they can't see. So this participant talked about sort of the ineffective breastfeeding support that she got in the hospital. So she said, "You're in the hospital and they're teaching you how to breastfeed. They do this thing where they hold the baby, they wait until the baby's mouth is open, and then they fly it on when they think it's the right moment. But that doesn't teach the blind person how to breastfeed at all. That makes the blind person totally dependent on having the nurse there to watch when the baby's mouth is open and then fly the baby on. So that doesn't teach the blind person how to do it themselves when they're at home, right? And several participants talked about this similar thing, whether it was participants who were blind, and also you'll see some with physical disabilities talked about how in the hospital a nurse or someone else specifically around breastfeeding would sort of do something and show a participant how to do something in a certain way. But then when they got home, there was no adaptations or supports about how they would do that on their own at home. So the participants with physical disabilities, these are just some themes that came up with those participants. So some participants talked about having to be their own care coordinator, and this was specifically participants who had a complex medical condition as well, or in addition to, dealing or seeing their perinatal healthcare provider, like their OB or family doctor, they also had a rheumatologist or another type of disability related specialist, and they also often felt like they had to be the one communicating back and forth between specialists. However, there were a few participants who had their care at somewhere like Sunnybrook, where there's now the accessible pregnancy care clinic for women with physical disabilities, who had talked about, how great it was that their care was coordinated, how all these different types of specialists did communicate, and they were all in the same center, all their appointments kind of happen on the same day. So that was something that was really great, but something that's not always feasible or possible in smaller centers and not in a lot of places. And then finally, many participants with physical disabilities also talked about gaps in postpartum care, specifically around their mental health and support around breastfeeding. So just a quote to speak to the first point about lack of coordinated care. One participant with rheumatoid arthritis said, "I recall being the person having to do a lot of the calling and appointment making and seeking out supports. I was communicating back and forth to each of my specialists about what I was doing." So not all of her healthcare providers were sort of on the same page about her care or what she might need or changes to medication and things like that. So this participant and a few others talked about having to navigate care and services themselves. And in some cases, this meant traveling to a different community from where they lived, often a bigger city, to get specialized care. Conversely, there were a few participants with physical disabilities who accessed a specialized clinic for women with disabilities in Toronto and had good experiences. This is a clinic where the space was accessible, appointments were coordinated, and they met with the entire team of different providers to talk about their birth plan, what might happen, connect them with resources, including in-home nursing support during and after pregnancy, helping them access adaptable equipment, so whether it be different wheelchairs or adjustable cribs, as well as connecting them in some cases with mental health and breastfeeding support. But again, I think these participants had a really unique experience accessing this specific clinic, and not everyone has access to such a clinic. So one participant said, even with a social worker, she directed me to get nurses after I had a baby, and even people to help me bathe during pregnancy. She was the one who, she went out of her way to get me that support. I felt like, oh my gosh, I felt like I had more resources when I was pregnant than throughout my entire life. So I think this quote is really telling how important and effective a clinic like this can be when someone with a disability feels they're getting so many supports during pregnancy and other times in their life that this is not the case. So despite this specialized clinic, there were still issues and challenges that women with physical disabilities told us about, such as feeling pressured to breastfeed when it just wasn't working, or that it was just very hard for participants. And almost every participant, and notably those with physical disabilities, shared that having more disability-specific services and supports would have made their perinatal healthcare experience better. So regarding breastfeeding in particular, and this sort of relates to the earlier quote from the participant who was blind, this participant said, "I can feed when I'm here in the hospital because someone else is going to do the latching for me, and then I just have to hold them. But when I'm home alone and my husband's back to work and my mom can't come to the house every single day. Like there should have been something, especially if they're going to pressure me so much to breastfeed in the first place, then there should have been some sort of support to help me. There was nobody to come home and to help me. Like I said, when I'm holding the baby, who's there to hold and all the towels, right? So this participant was talking about when she was in the hospital before she left with her baby, there was a nurse there to sort of stuff towels in different places to kind of help her prop the baby up. But when she came home, there wasn't such, no one there to really help her. So I'm just going to provide a quick summary of those findings and then hand it over to Momina to talk about recommendations from our overall study to hopefully improve clinical care for women and people with disabilities. So just to summarize, as Hilary noted with our Ontario Health Administrative data, pregnancy is not uncommon in women with disabilities. I think the number was 1 in 8 pregnancies in Ontario in 2017 as to women with disabilities. However, there's clear evidence of significant health disparities in the preconception period and also perinatal outcomes among women with disabilities compared to those without. The interview participants identified a number of barriers and challenges related to accessibility, including communication, as well as barriers related to attitudes, physical spaces, providers with a lack of knowledge about disability. And we're finding especially that there's a lot of gaps in postpartum care. So it seems some participants got fairly good care in pregnancy, labor, delivery, but sort of after the baby was born, it's sort of like you're on your own, good luck. And I think that's common for many women, disabled or not, but I think for women with disabilities, especially I think women with physical disabilities who are often treated as high risk or closely monitored and given a lot of services and supports during pregnancy, and then to not have any of that available during the postpartum period seems sort of odd. So there's really a hyper focus on disability during pregnancy and offering supports, but then once the baby is born, services and supports really drop off, and there aren't a lot of specific services and supports for women and parents with disabilities in the community as well. So I'll pass it over to Momina now.
Awesome, thank you so much. So yeah, I'll be talking about recommendations, but before I do that, next slide, sorry. Before I do that, I just wanted to touch upon the considerations of the study. So from our population-based data, it's important to note that our findings are limited to women with a disability diagnosis, and that we're also limited in our ability to account for factors like race and ethnicity, as well as health behaviors, because this information is not collected. In terms of our qualitative data, it's important to note that only a few participants had sensory disabilities, specifically vision loss, and only a few were from Western Ontario. In addition to this, we know that today we highlighted many negative experiences, but some of our participants shared positive experiences as well. And this includes healthcare providers who actually went out of their way to provide support for people with disability. So I'm going to start our recommendations section by providing 2 recommendations from people with disabilities themselves. So a participant with IDD described how they need healthcare providers to be more open, listen to clients. It's not easy to have a disability, nor is it easy to go in and face it alone. Also give more resources, help clients find places that can help them instead of saying, well, you have a disability, let's write down your faults. They need more support, someone to talk to and not be so rushy. Another recommendation by someone who was deaf said that, get an interpreter from the get-go because it's for them. The interpreter is for them, meaning the healthcare provider, not for me. During pregnancy, if a baby has a heart problem, they bring in a cardiologist to focus on that problem. So the interpreter is the same thing. Get the interpreter in the first place so that you're preventing any other miscommunications and misunderstandings that could happen in the future. So based on our findings, our first recommendation is really to take a life course approach to understanding reproductive care in this population. And so it's important that we start sexual health education and preconception care at an earlier stage, and then really continue this across the first year postpartum, as well as interconception care. Our second recommendation is for there to be increased collaboration between service providers. Often what happens with these complex cases is that service providers are working in silos, and so it becomes really challenging to deliver the most effective care. And so, as Dr. Cherisoff mentioned previously, Sunnybrook is an accessible pregnancy clinic that seems to be the only clinic of its kind in North America that strives to provide this integrated kind of care for people with physical disabilities throughout their perinatal stages. And so they have several measures in place, one of which includes like accessible mobility equipment, which really accommodates different needs. So going off of that, there is really a dire need to make the perinatal care setting more accessible and including communication health information to women with disabilities in a variety of ways that actually meet their unique needs. So this can include things like using images and videos instead of just written material, and always having interpreters present, as the participants mentioned in their quotes. At the institutional level, people with disabilities can really benefit from more frequent as well as longer appointments, and home visits, particularly in early postpartum period, are especially useful. So importantly, and as much as possible, perinatal care providers should work proactively with women with disabilities and their supports to ensure that resources and supports are in place. So this can be related to their disability as well as other life circumstances such as social and financial supports, and that these are really in place early in pregnancy. And then finally, and most importantly, in our opinion, perinatal care providers should ask women with disabilities what actually already works for them, and what or who they may need to feel more informed, more comfortable, and supported during their pregnancy, labor, delivery, and in the postpartum period. So it's really important that we don't make assumptions or dismiss any of their concerns. So with that, I'd like to end our presentation by sharing some resources where you can learn more about perinatal health among people with disabilities, and these slides can be shared with you. Thank you.
And I'll just note that I think the slides will be shared, and the resources, you'll find links to a number of our publications. So far we've published a number of papers specifically using the health administrative data, but we'll have some qualitative papers hopefully within the next few months, the next year. And here's some other specific resources that are in Toronto and Ontario, but we know there's also some really great research happening in the US too. So we have a link to the National Center for Parents with Disabilities there, as well as a paper by one of our colleagues in the States, Monica Mitra, who does a lot of work in this area. And she outlines a perinatal framework for women with physical disabilities, but I think this framework could be used for women with a variety of disabilities in terms of things to think about at multiple levels, institutional, provider level, individual level, in terms of things to think about when caring for women with disabilities in the perinatal period. And we'll just close off by saying thank you to you for listening, and to our advisory committee and many students and colleagues who participate and contribute to this work. So thank you so much.
Amazing. Thank you so much, Leslie, Hillary, and Momina. What an amazing, research that's being done. And I think it's so important, especially for our interest group here. And I think it would be so great if, there could be some partnership or something with the RNAO to publish like guidelines regarding perinatal health and pregnancy, which is really important for, practice changes to be able to accommodate and adapt to the patient care needs. We have one question so far, and guests, please feel free to ask any questions at this time. Question from Amanda. Is there a resource for nurses who are interested in learning more about care for women with disabilities?
So I'll attempt to ask that. So I don't know of a specific Canadian resource for women with disabilities. I know of a few American things, but they're quite dated, but a number of the resources there might point you to things or give you ideas. And I can also share that recently I'm a co-author on an SOGC guideline about caring for women with physical disabilities during labor and delivery. So I can share that resource as well. But so it's an SOGC guideline, but I think some of what's in there is relevant to nurses too.
Perfect. Thank you.
Actually, I can put that in the chat actually. Happy to answer any and all questions. I know we covered a lot.
Susan has a comment. She said, interesting challenge to balance support for breastfeeding and need for formula feeding. If there's any comments on that.
So I can attempt to answer that. So I know from this work and my PhD research that focused specifically on women with physical disabilities that many women want to breastfeed, but there are many challenges too. I think it depends on the type of disability as well. And, if there's any types of medications they might need to be on or get back on after a baby is born. So unfortunately, there isn't a great deal published specifically around breastfeeding experiences and supports of women with disabilities, but we're hoping to tease that out more in our data. So I can't say like a blanket, all women should or shouldn't, but I think the message sort of is that if they want to and they can, they should be supported. And I think there just aren't a lot of breastfeeding specific supports for women with disabilities. So that's something to look into and to think more about.
Yeah, and just to add to that too, one thing that we've heard even from members of our advisory committee who are parents with disabilities as well is they would appreciate also more supports for the providers themselves. So lactation consultants and that sort of thing often have no resources about disability themselves. And so if a person with a disability goes to a lactation consultant for help, often they're sort of trying to figure it out together. So I think that finding, as well as a number of the other findings from the interviews that Leslie did, really show the need for provider education as well, just to make providers feel more comfortable in supporting new mothers.
Awesome. Thank you. Our next question comes from Evelina. She says, what a great presentation. Thank you. Are you aware of services specific to parents with physical disabilities in Ontario with regards to parenting, like adaptation, skills, training, etc.?
So I think the question is about physical disability. So I know the Center for Independent Living in Toronto, through their Parenting with a Disability Network, does a lot of that work in trying to connect people with services to get adaptable equipment. And I think through the Ontario Federation of Cerebral Palsy, there's someone working to do that too. And there might be a number of other groups. I remember one participant, I don't know if this is specific to Ontario or it might be North America wide. I think they said the Tetra Society, something like that, was also a resource that helped connect them. And then there were just a few participants. I was reading a transcript today who just happened to connect with an occupational therapist to work with them to figure some things out. So I think there are sort of a sprinkling of those types of services, mostly I think in the GTA, but then people individually finding an OT or someone that helps them, access those things, or sometimes people getting things made that aren't quite to code or to Health Canada standards in terms of adjustable cribs and things like that, but people just want to make it work for them, so they adapt things. And I've heard people and their partners sort of creating all types of devices and things like that to make, parenting work for them.
Hi. Can you hear me okay?
Yes.
Yeah.
Great. Emily just asked about my experiences and with women with disabilities through prenatal teaching specifically. And I'm also a lactation consultant. So really resonated with me when you mentioned women going home and, trying to manage breastfeeding on their own. And I can certainly think of women, who maybe had a stroke and had very limited ability to lift and position babies, and what a challenge, right? To figure out how they're going to manage 24/7, right? Like in the hospital, we came up with some strategies both before and assistance, after they'd had the baby, but it's a long journey. It would be nice to have more resources, and the women themselves, this group that you interviewed, and I don't know if there's a way for them to specifically share some of the things that they did, because I know, Hillary, you mentioned that, that the lactation consultant and the mother were figuring it out well, and that's what we do, right? But it would be nice to share the benefit of some of those experiences. It would be, I'm not quite sure what that would look like, but this is such a great start, like just the information that you've provided tonight. The other thing that went through my mind when you asked me, Emily, is that I've certainly in the prenatal classes, we've had some hearing impaired couples, one or both, and can be very challenging. It's hard to get the closed captioning. I'm still trying to find it for our Zoom sessions in the hospital. Talked to lots of different people, but we just I can't seem to find that one person that helps me pull it together. And the other thing is, we've had couples that, we've brought in an ASL interpreter, but you had to have two of them, like for a full day class, and it was complicated, right? And so there is a legal requirement that we provide that, and so for us it was the challenge. Do we do a private one-on-one class, with a couple? But they didn't want that. They wanted to be part of the prenatal class experience. And so we ended up, well, there have been a few different situations, but this one particular situation, we had two interpreters who had to trade off because it was a long day, and the interpreting, I'm sure, was tiring. So yeah, there's lots to think about. So I don't know if you have anything to add to that, but that's what came to mind as I was listening to your presentation. Thank you. It's very, very helpful.
Yeah, one of the things I think of as you're speaking is the challenge that we're coming up against now that we're at the stage where we're thinking about recommendations and how to get this information out there and how to help people provide the care that these women need is, should it be a centralized resource that providers across Ontario can go to if they need help? Because oftentimes it sort of feels like there's sort of one-off sorts of resources that maybe you know about, but maybe you don't, depending on who you talk to and someone's recommended to you. And so that's one of the things that we're sort of trying to sort out now is, do we, is it a website that's helpful for people to go to that's a list of resources in their area? Is it a champion at a certain institution who's sort of the person that knows extra information, or is it broad education of healthcare providers? I think it needs to be a combination of all of those things, but it is really difficult when you know, any individual provider may only see a handful of people with specific disabilities in their practice over time. And so how do you give them the right resources? It's an interesting challenge that we're trying to work through right now.
I think the other thing is that, you know, the parents that were commenting on needing to coordinate their own care. I mean, I work at Mount Sinai. We have a lot of people who will come together. And so while I'm not sure that we have a separate clinic, but we really do have a multidisciplinary approach. But at the end of the day, it's just so important to have those parents be really involved in coordinating their care. And so I guess it's just, we need to make it easier for them to do that, right? In a way that it's not all on their shoulders, but that they do direct the rest of us, right? So yeah, I'm not quite, again, it's like, how do you share that information? The resources that you've posted will be very interesting, because I don't know if some of these resources, if they've begun to do that, certainly listening to the stories that parents tell is very helpful. I mean, it really, you know, broadens your perspective, and I think if we could do that ahead of time, you know, when we're working with these families, it may help us with our problem solving, just to listen to how people have navigated their different challenges.
I think you make an important point. So I know a few participants who had their care at Mount Sinai and generally had good things to say. So that's good. But I think it's a tricky thing too, in terms of the coordinating care piece about, you know, someone in northern or rural Ontario versus someone in Toronto and what they have access to, because some participants did have to travel to different or bigger centers to get more specialized care. So that's one thing too. So I think it's tricky, like Hillary was saying, sort of what are our solutions? Is it broad education, or is it sort of that point person in one LIN or one hospital? So I think there's so many tricky things. And then also thinking about the different disability groups. So there might be in some communities, you know, more people with specific disabilities, or, you know, healthcare providers only encounter a handful of people with, say, cerebral palsy in their entire career. So it's really tricky, you know, in terms of how specific the care should be or how much people should know versus kind of broadly understanding disability. And I think the point Momina made at the end of our presentation is just so important about asking women and people with disabilities about what already works for them, or what they need to feel supported, or who they need to be involved in their care. And sometimes many women with disabilities talk about how exhausting it is to always be advocating for their care, or pushing for things, or asking questions. So for some of them, it's really important to have a support person or someone else there who can sort of be their voice when, you know, you're in labor and you're tired, but you're trying to advocate for something.
Yeah, and I think the tools that we use, so they don't have to keep repeating their, you know, their story, their information, you know, what's necessary. And so much as, you know, people roll their eyes about birth plans, well, these plans, this kind of communication tool, whatever you call it, can be so important and so valuable. And the other thing I wanted to say is I do think that we're all really good at Zoom now. And I think that we are going to be able, you know, I think we're all going to benefit in terms of the not traveling. I know at Sinai, the families that have been coming from far and wide, they're definitely, even when we go back to in-person appointments, there's going to be a lot more continuing to use this, which I think will make a big difference to many families, but particularly parents with disabilities. So a silver lining, right? A very small one.
Yeah. I also just wanted to mention, and Hillary, maybe you can speak to this better than I can, about kind of something that's in the pipeline that we've been working on in terms of the sort of kind of to go with the birth plan, the tool that we've been working on for people with intellectual and developmental disabilities.
Sure. Yeah. So some of the work that we do is with Health Nexus. I think probably many of you are aware of the work that they do Best Start Resource Centers is a part of Health Nexus, and I'm sure many of you use many of their tools, but they have a number of childbirth support tools, as well as support tools for perinatal mental illness and that sort of thing. And one of the tools that we're working on at the moment is related to supporting prospective mothers with fetal alcohol spectrum disorder. And it's a neat tool because it sort of walks you through the different considerations that a person might have, whether it's sensory needs, memory needs, organizational needs, and that sort of thing. And I believe it's being finalized later this month. And so that's some in progress work that I think could also be replicated for other disability groups in terms of recording that really specific accessibility related requirements and supports that women need. And I think it speaks to the comments that Leslie and Susan made earlier about just the need to give women that sort of thing that they can take with them to give to different providers to say, okay, I've already written down all the things that you need to consider. Here it is. You know, you don't need to repeat your story so many times. And it helps providers feel like they have the resources that they need as well to understand women's unique needs. So we'll maybe be able to share with the group that resource once it's finalized.
That absolutely sounds amazing. I actually have my placement in the ACPC clinic at Sunnybrook tomorrow. So I am so excited to see kind of with this history and background and the statistics fresh in my mind and see how the clinic will run tomorrow.
Great.
All right. Any last comments or things you want to cover today? Leslie, Hillary, or Momina?
I would maybe just quickly add, I think all this information that we're learning about maternal disability is an important part of a broader conversation about health equity. I think a lot of the accessibility related needs that we see among women with disabilities, you can see parallels in other population groups, whether it be newcomers who maybe need translation services, that sort of thing, you know, other groups that may experience marginalization in different ways. So that's been a helpful lens for me in terms of thinking about the outcomes of this study, because I think although the specific considerations that we're talking about do relate to disability specifically, it is part of that broader conversation about how we improve health equity and just gets us thinking about how we can tailor supports to other population groups as well. So I think that's something important to keep in mind.
And I think for me, just the reminder of that, you know, pregnancy isn't that uncommon in this population. So 10 or more years ago, when I started doing work in this area, we had no Canadian population-based data on how many, you know, the pregnancy rates of women with disabilities. So we have that data in Ontario now, so we can say, you know, this is happening. It's not just, you know, anecdotally a few women here or there. So I think that's really important to remind people. Granted, that includes like a wide range of people with disabilities, but I think it's really important that people recognize that. And, you know, maybe there are some people with disabilities that, you know, have been in your practice, but you just didn't know because maybe they had an intellectual disability and they didn't disclose it, or they had like a physical, like an episodic disability, so it's not always visible. So I think just thinking about accessibility and making things accessible and thinking about different people's learning and communication needs is really important. And like Hillary said, the broader lens of health equity is really important. And I think for me and maybe us doing this work, I think just pushing that disability is included when we talk about health equity. So I think now healthcare providers are doing a lot better, or at least I hope, around, you know, racialized communities, LGBTQ populations, and other marginalized groups, but disability still is a little bit behind, especially in terms of education and training. But I think with the context of COVID, a lot of topics and conversation about disability has been coming up. And
Awesome. Amazing. Thank you, all three of you, so much for presenting tonight. And I can't wait to see where the future of your research continues to grow. And hopefully we can start seeing, you know, implementations of these recommendations in our nursing practice. And I'm excited to be able to hopefully be part of that one day. So we're going to conclude tonight's webinar here. Again, the recording will be available on our website, so please check it out at mcnig.ca. Have a lovely evening, everyone, and take care.